Hey, good morning, everybody. My name is Taylor Burkholder. I'm an assistant professor in the Division of Global Emergency Medicine at the University of Southern California, recording from Los Angeles today. I've been asked to give you a short overview of governance in the emergency care system. Um, Governance is what I like to call the neglected health system building block, so I'm excited to talk to you a little bit about this. Sorry I couldn't be there with you today. I am currently recording early so that I can make a flight to a friend's wedding in DC. But if you have any questions or want to start a conversation during this talk and you use Twitter, feel free to tweet me at the Twitter handle below at @Burkholder. I will hopefully have internet and be able to respond and get a discussion going, since I apologize that I can't be with you at the boot camp here today. Um, I have no disclosures to make for this lecture. Um, and I wanted to start off with this quote by the late Kofi Annan, former UN Secretary General, who said, "Good governance is perhaps the single most important factor in eradicating poverty and promoting development." And he says this in broad terms of development in the global perspective, not specific to health systems, but I think it's pretty applicable to the work we would like to do in the emergency care system. So for today's objectives, wanted to briefly define governance and then review the key concepts and basic frameworks of governance, and then talk a little bit more about why governance matters before we move into the key components of governance that are mapped out in the World Health Organization's emergency care system framework, and wrap it all up with a brief example on that. So in order to define a broad concept like governance, it can be pretty challenging, and it really requires someone to look at the perspective of the organization or people that are studying governance. I like this definition for the most part that's provided by the United Nations Development Program. And in it, they say that governance is the exercise of political, economic, and administrative authority in the management of a country's affairs at all levels. And I think because the UN Development Program, they're thinking specifically about the country level or nations' ability to perform governance, but governance can actually apply to things other than nations, so it might be a little bit too narrow of a definition. They then go on to say that it comprises complex mechanisms, processes, and institutions. So these are some of the inputs of governance through which citizens and groups can articulate their interests, mediate their differences, and exercise their legal rights and obligations, which are some of the outputs, at least the proximal outputs of governance. If you're a fan of the keep it simple approach, then you can use this initial definition of governance provided by the World Health Organization, which just says that governance is the activities through which society organizes itself to achieve collective ends. And so what both of these definitions include, and trust me, there are many, many more definitions out there if you want to take a look at the literature, they both include some element of a whole bunch of people or players or stakeholders and actors coming together to try to negotiate the method by which they want to achieve something. And specifically in the health system, that might mean achieving some type of health outcome. And I wanted to point out that there's a difference between governance and government. And I think we use those two synonymously. And for the most part, all government probably is some form of governance, but there are portions of governance that are outside of government itself. So for example, governance, I think, suggests activities that are backed by formal authority, whereas governance refers to activities that are backed by shared goals. They may or may not derive from a legal or formally prescribed responsibility, and they don't necessarily rely on things like police powers to overcome defiance or to attain compliance with the population or whoever it's directed to in terms of that policy. So that's an important distinction. For the purposes of this talk, we will focus a lot of our energy on government as health system academics. That's oftentimes what we will or who we will interface with the most. So what does governance do? What are the key functions? Before we really used the term governance, the World Health Organization defined something called the stewardship domains of the health system. And I think those are loosely translatable to governance too. They said that stewardship involves intelligence gathering, so understanding and processing data, strategic policy planning, so coming up with the agenda to achieve better health outcomes, then finding incentives or providing sanctions that create an environment that allows those processes that need to happen to achieve the health outcomes, which will also require coalitions and partnerships to be built and directed. And then another stewardship domain is achieving fit of policy objectives with organizational structures and cultures, which can be a very difficult task, and one that unfortunately there's not a ton of guidance as of now, but it's an area of future research. And then finally, accountability. Accountability is probably one of the most important functions of governance, and it's important because accountability refers back to our ability to accomplish the previous stewardship domains, including intelligence and strategic policy, incentives and sanctions, and all of these. So without accountability, you're unlikely to achieve these other functions. Taking a step back and looking at governance in the context of the health system building blocks, this is a diagram that's adapted from the World Health System, the World Health Organization's health system building blocks. And in it, you see these 6 health system building blocks, including service delivery, health workforce, information systems, medicines and technologies, finance, and governance. They're each depicted separately, and then they all unite through this process that involves access, coverage, quality, and safety to yield certain health outcomes, or outcomes in general, which include improved health, responsiveness to the needs of the population, financial risk protection, which is a very important topic in this era where the World Health Organization and other bodies are focusing on universal health coverage. And finally, improved efficiency. So we use resources appropriately to achieve those outcomes. Now, what I don't love about the way that this is depicted is that each of the health system building blocks kind of stacks alone to build the health system, when in reality there's a lot of cross-cutting between all of them, but particularly for governance and financing. So the way I like to conceptualize it a little bit more is something like this, where governance and finance are truly cross-cutting. They're more like the mortar between the bricks, because every single one of these other building blocks, including health workforce, service delivery, information systems, and medicines and technology, and even definitely finance, they all require some type of governance to achieve what they need to achieve and to do it effectively and efficiently. For example, when it comes to the health workforce, in order to build a health workforce, particularly in emergency care, you need a method for training and credentialing the healthcare workers, whether that's nurses or advanced practitioners or physicians. And that requires regulations that govern things like licensure, scope of practice, how the training institutions are funded. All of these require some governance function. For information systems, we might be best served by having some type of central process that allows information to be shared between facilities to notify for infectious disease, like syndromic surveillance, as in the case of like the West African Ebola outbreak, or other things that the registry can accomplish, like benchmarking and quality improvement for the whole system. And so for that reason, governance is an essential component that helps the information system achieve those health outcomes. Now, the question of why governance matters is an important one. I think everyone will agree that governance is here to stay. It's going to be involved in every health system that we might work in as academics that are interested in studying or developing health systems in low and middle income countries particularly. And it'll vary depending on the government structure in whatever country we are working in. But there's definitely a question about how important governance is, especially how important it is to achieving certain health system outcomes. I like this paper that's shown here because it is a systematic review that found approximately 30 papers that looked at some function or measurement of good governance and then tried to tie it to specific health outcomes. And what it found is that the vast majority of these papers showed some type of direct or indirect linkage between governance and improved health outcomes. Some of them were a little stronger than others. And so there's definitely variability depending on what the health outcomes they were trying to measure. And there isn't a great standardization of how these studies looked at this, but it does show and start to build a good argument for some attention being paid to governance of a certain health system. looking specifically at health system performance in sub-Saharan Africa, this study tried to look at governance, health outcomes, and then also added the layer of equity. And unfortunately, what it found is that better governance did in fact improve health outcomes once again. But when it looked at marginalized groups, vulnerable populations, or inequities within the healthcare system, good governance improved outcomes primarily for those that had better access already. So it did not do it with good health equity. And I don't think that the purpose of this paper is to criticize governance and say that governance cannot accomplish good health equity. In fact, I think it's probably one of the most powerful tools that we can use to improve the equity of our health systems, particularly the emergency care system, because governance involves things like laws and regulations that might require non-discrimination. So it is an important tool, but at least as it's being implemented right now, it doesn't seem like there's been enough focus on governance and equity. And I think that's what this study is primarily showing. Now, one thing that's important to know is the barriers of achieving good governance to reach those health outcomes. The USAID list here, I think, is a good place to start. It lists several different barriers. The probably biggest one that is seen in most studies is corruption. Unfortunately, corruption is very common throughout much of the world, including right here at home in the United States. And corruption creates a lot of inefficiency. It wastes money, it diverts money, it creates a lack of trust in the health system. The really unfortunate part is, as people working within the health system, corruption usually extends well beyond the system that we work in, and it would require a large reform to the entire government and governance structure of a country, which can be pretty difficult to achieve, especially with the types of work we might do. But it's something to acknowledge and realize going into a project that might involve some element of governance, that you might need to anticipate that as a barrier to achieving some of your goals. The other ones include things like weak incentives and weak sanctions, which obviously provide less motivation for people to adhere to a policy or strategic agenda. Limited engagement of citizens not only means that the policy that is trying to be developed, or that we're working on developing, is probably not the best or most accurate one, but it also has less buy-in from citizens to then help enforce it, which leads to poor accountability. And especially if the general population does not have any mechanism to report any deviation from policies, then it's unlikely to be accomplished. And then poor transparency also makes it pretty difficult to be accountable, but it also makes it difficult for the general population of the citizens to understand what's going on and to provide feedback in real time to improve the health system. So any type of politics or governance is going to involve a whole bunch of relationships, and those relationships and the dynamics and the power points of those are really important to understand when you approach a governance problem. I think one of the more realistic and forward-thinking ways to conceptualize those relationships is through a theory called the principal-agent theory. And basically what that says is that there are principals, which are the citizens, the people, or groups of people who have specific aims and goals, but do not have the means themselves to accomplish them on a day-to-day basis. So they delegate some type of power or authority to agents, which are often legislators or parliamentarians or ministry officials, to be able to act on their behalf to achieve those aims. Now, problems arise and on a couple fronts. One is that the principals and the agents might not have the exact same motivations. For example, the agents might be motivated on re-election, in which case they might care a little bit more about a subset of their population, like donors, and what their opinions are on a certain policy agenda. And in that case, they may act in a way that doesn't fit their entire constituency, the principals, but only a few of them. They also have access to a lot better information in general than the principals. And depending on the level of transparency, they might not share that information as well with the principals, nor are the principals always rationally invested in learning all of those things in their day-to-day life. So agents can use that asymmetry to their advantage. And that is one of the reasons why corruption and other barriers in good governance exist. So by thinking about the different players that are involved and actually creating a map of your stakeholders and actors within the emergency care system or whatever health system you're studying, you can actually understand these power dynamics a little bit better. In this diagram from an article by Brinkerhoff, you see a description of the different relationships of the principals and the agents in a health system. Starting at the bottom left of the screen, where the citizens are, or the groups of citizens, they're almost always entirely principals. They almost never act as agents, but the other two groups can act as both principals and agents, depending on the type of relationship and the task that's at hand. So the citizens are almost always looking for services from providers, which could be the clinicians, the nurses, the public health workers, or anybody else who acts as a provider in the healthcare system. And so they're asking for that, and they're sometimes providing some feedback and input into what they want out of their care. Then the providers can act as agents or principals, especially principals when it comes to their relationship with the state. The state could involve things like the Ministry of Health, or for the emergency care system, some of the regulation and oversight actually comes from things like the Ministry of Transportation, especially in the case of a lot of the pre-hospital regulations, or the Ministry of Finance. Legislators as well, parliamentarians and their subcommittees of the legislation. All of those can be some of the agents that will dictate certain directives and oversights and policies and guidelines towards the providers, and they will then ask the providers to provide information back to them in the forms of reporting, maybe even lobbying. And then of course the citizens ask that the state become far more responsive to their needs, and they then provide their feedback and their goals and aims towards the state policymakers and politicians. So when you think about this and you map out the dynamics, you start to get a picture of how complicated the formal and informal processes within governance are. And that leads you to the next step, which is trying to figure out how to assess whether governance is good or bad, and whether it's productive in terms of achieving the health outcomes that you're looking for. Now, you can do that from the big picture entire health system, or you can look at one particular issue within the health system, which we'll do a little bit later here with an example from emergency care. There are a lot of different tools and frameworks out there that look at health governance and whether or not it's effective. But the most comprehensive one that I find the most usable is this framework by Siddiqui and colleagues, which incorporates several other frameworks and best practices from other academics, but also from the World Health Organization, the United Nations, and the World Bank in terms of their development programs. And what it does is it creates this largely qualitative tool that can be used based on key informant interviews, focus groups, primarily from the government and ministries, but some from the general population too. And it uses that information to give you a qualitative assessment, much more so than a quantitative answer as to whether or not the governance is doing what it's supposed to do. Because it's qualitative, there's a lot of limitations, and because it's coming from key informant interviews, you do have to interpret a lot of that loosely. But it's at least one of the better tools we have for assessing governance towards a specific policy or health system. And what it does is it establishes these 10 domains that include strategic vision, participation and consensus, the rule of law, so how strong and enforceable it is, transparency, responsiveness, equity and inclusiveness, effectiveness and efficiency, with a particular focus on cost effectiveness. Of course, accountability, which keeps coming up in this talk. Then the information and intelligence that's gathered and how it's used and processed. And of course, the ethics of what's being done on the governance level. So each of these 10 domains has some kind of subdomains and a list of questions in this tool that can be used. The questions are pretty broad towards the health system in general, but they can be focused and adapted for the emergency care system. In this paper themselves, they actually apply it to the health system in general in Pakistan in a nice example that I encourage you to check out if you're interested. So finally, let's take a deep dive into governance and emergency care specifically. There are not a lot of documents that exist that discuss what governance and emergency care even looks like. So the best one that we have, in my opinion, is looking directly at the World Health Organization's Emergency Care Systems Framework. And specifically in the column that's highlighted in red towards the far right, you'll see leadership and governance as one of the cross-cutting blocks that they use. And the WHO ECS framework divides things into scene, transport, facility, and some cross-cutting elements. So in the next few slides, I'll pull out a few select examples of what governance looks like, especially on the more formal government-focused perspective. Starting at the scene, there are some legislative mandates that are called out in the framework, including the establishment of a universal access number, something like a 911 in the United States, that allows people to call for help and arrange transportation where available. Laws that might be important on scene are things like a bystander protection law, what we call Good Samaritan laws in the United States and many other places. This is necessary because if you don't have a robust pre-hospital system, and I think you've already had a talk today on some of the pre-hospital system, and if you don't have that functioning, then the next best thing is to engage the community to provide first aid and basic life-saving care until someone can reach a destination facility that can provide emergency care. But if there are disincentives such as legal risks or the threat of harassment by police or patients' family members, then that imposes a pretty strong barrier. So passing laws that protect bystanders from that kind of work will incentivize them to become part of the pre-hospital response. And then of course, there's less formal things like guidelines and protocols. So pre-hospital treatment protocols for your pre-hospital providers, minimum standards of care, and what's required to be stocked on an ambulance. Transportation and referral protocols are also very important, especially when certain destination facilities might not have the resources that are available, but another one 15 or 20 minutes away does. Moving into the facility itself, there are legal mandates that are suggested. This, I think, is probably one of the most important topics that I'm passionate about. So I'll talk a little bit more about guaranteeing access to emergency care without regard to ability to pay in a few moments in some more slides. But then there are tons of protocols and guidelines that are necessary for the actual facility-based emergency care. Things like triage protocols that require a triage and dictate how it's done. Levels of care guidelines for the types of resources that are available at district or regional referral hospitals, all the way up to tertiary hospitals as well. And then scope of practice for the providers that work in those facilities as well, along with best practices. Then looking at some of the cross-cutting features that are called out in the framework, there are negligence and malpractice laws that are necessary to govern the relationships between providers and patients. And these may be general in some countries or non-existent, but they might not adequately protect the providers working in emergency care in specific and very unique settings. So having something that is specific to the emergency care system is a good consideration. And then guidelines and protocols like standardized reporting and information gathering, such as a registry. And then coordination for disasters, emergency response, and crises is also very important. I think there's a lot more science out there these days that shows a robust emergency care system makes for a resilient health system when disasters and crises strike. But without central coordination from some level of government, it's unlikely to be able to pull together the resources that are necessary to avert a lot of death and disability. So to finish up, I just wanted to apply some of that to one topic within the emergency care system. And that specific topic is accessibility of emergency care. So if the goal of the emergency care system is to provide universal access to emergency care in a timely manner and to all people in a non-discriminatory fashion, with good quality of emergency care to all people, not just to some, then some element of governance is probably going to be needed to make that happen. And you can approach that from a couple different arguments. I think the most common one we see, and the one that a lot of our colleagues are working on building the case for, would be that emergency care helps us avert death and disability for a whole host of conditions, so that we might actually improve the overall health of the population and the economic productivity too. But there's a whole nother argument that can also be used that I think actually applies to existing obligations that governments have, and that's using a rights-based approach. So there's a legal basis here in that a whole host of international treaties talk about this right to the highest attainable standard of health dating back to the 1960s. I think there are over 12. And as of last count, every single country in the world is a signatory to at least one of those treaties, meaning they are legally bound to follow up on that right to health. Now, whether or not that's being followed and enforced is another matter. But I think one thing to point out is that this right to health discusses four essential domains, what they call the AAAQ framework. And that stands for availability, accessibility, acceptability, and quality. And so accessibility of something like emergency care fits directly into that right to the highest attainable standard of health. And they make a particular point in talking about accessibility in terms of non-discrimination and protection and affordability for vulnerable populations, marginalized populations. So I think that's really important to keep in mind when we talk about governance of an emergency care system, particularly with regard to accessibility. Now, of course, not all countries are going to be able to enforce or protect a right to the highest attainable standard of health at the same level. So given their resource availability, they're supposed to start with certain core minimum obligations, of which there's 6, and 4 of them directly relate to emergency care, and that's time for a whole nother lecture. But because those core minimum obligations can't be fulfilled without emergency care, it provides a nice argument for us to approach legislators, governments, to say, hey, let's build some emergency care and let's make sure we guarantee accessibility to it in a rights-based way. Once we've established an argument like that, you start to look to what our mechanisms are, our processes that we can achieve good governance regarding that. And so I'm going to go one by one through some examples of these here. For example, laws can be either constitutional in a constitution, which are usually pretty aspirational, vague, guiding principles that might define a right or a certain tenet that the government should respect or promote. They're a little bit different than statutory laws, which we'll cover next. But for example, here are a couple different examples. South Africa has a constitutional provision that says no one may be refused emergency medical treatment. It's pretty vague. I don't know how to define medical treatment or emergency medical treatment here. I'm not sure what it means to be refused it or what's obligated, who's obligated, what the scope is of what you actually have to provide. And what you don't have to provide what's the limit of emergency care. But it at least starts the conversation on defining emergency care as a right. Nepal also has a constitutional amendment that talks, a provision that talks about emergency care, and it says every citizen shall have the right to seek basic healthcare services from the state, and no citizen shall be deprived of emergency healthcare. This one's interesting because, again, I don't know what emergency healthcare is or what it means to be deprived it. But this one specifically calls out every citizen, which does not include migrants, like immigrants, migrant health workers, refugees specifically. It might be of importance in this area. So the non-discrimination part of it does not seem to fit with this level of governance. Now, moving on to statutory laws, these are the acts or bills that are passed by a parliament or a legislative body. They're often a little bit more detailed and prescriptive. So for example, Kenya in 2017 passed a National Health Act that talks a lot about emergency care. And this happened shortly, maybe within a year or two of them passing a constitutional law in their new constitution that looks a lot like the South African constitutional law. But they went a little bit further to define what emergency medical treatment is, to establish the right, or reestablish it since it was already in the Constitution. It even sets a penalty for facilities that violate it, a certain monetary penalty. And then it clearly defines the scope of the law, so who it applies to, where, in both private and public institutions. And then it delegates the supervision and responsibility, the authority to do that, to the Ministry of Health to follow up on. So this is a lot more detailed, and I'm still waiting to see to what level this law is actually implemented and enforced, which is one of the important parts of good governance. But it does go one step further to establishing like clear access to emergency care. Now, court rulings are another way for citizens primarily to achieve their aims or to file complaints when they feel like their rights or what they're entitled to is not being provided. There aren't very many examples of that being used for emergency care yet. It might be one potential tool that we can use in the future. And it's been very effectively used in over 50 cases for the right to essential medications, for example. But I haven't seen many cases coming out in emergency care yet. Moving on to regulations and protocols, these are a little bit more loose, a little more difficult to enforce, although depending on the administrative structures of ministries, they might have some ways to enforce them. But this example comes out of Ghana, where the Ministry of Health passed an accident and emergency services guideline or protocol in 2011. And it defines what emergency care is, talks about the scope that is required, the types of services, including triage and stabilization or transfer where certain resources don't exist. And it also requires that they follow a specific type of triage process. And then it also sets up a system of financing emergency care, which is a lot further than most countries that I have looked at so far. And it does that so that they can guarantee that no one will be asked for money during the first 48 hours of their stabilization after an emergency. Again, I don't know how well this is enforced. It would require a lot more studying, but the policy exists as a regulation. And then finally, there are professional societies for the specialty in a lot of different locations. These kinds of things like ASAP provide clinical policies and protocols that people can use to establish standards of care. So all of those are mechanisms for health system governance. And I think in the interest of time, I'll go ahead and leave you with a few of the highest yield readings. So if you're interested in learning more about health system governance and taking a deep dive into it, and joining me in some research onto how best improve governance of emergency care systems, these are my top 3 reads that you can easily find online. And if you want to take an even deeper dive, here are some references. So with that, I will leave you with my email. Again, I apologize for not being able to be there in person today, but feel free to email me here at taylorburkholder@gmail.com, or find me on Twitter and reach out if you have any questions, or if you're sticking around ASAP, maybe I'll see you later next week.